Hello.
Hello.
Yeah.
Yes.
Good morning.
Good morning.
Today we will discuss a
Today we
word
will
round scenario.
discuss a word-round scenario.
This will be a general management of a trauma victim. With us today will be Dr. Diptaman Nandi and Prosenjit Basu, who are second year junior resident at MR Bangalore Hospital. And our teacher will be Professor Shomita Chatterjee, who is a dedicated trauma person and professor of surgery at IPGM and SSKM Hospital. So I give a scenario. A 30-year gentleman has made a road traffic accident and has been brought to ER in an unconscious state. And you are in ER as MO, and you are going to manage this patient. Okay, so Dr. Chatterjee will take us to a few questions. You just listen to the question, answer specifically what they're going to do. Yeah. It's an unconscious patient, a trauma victim.
Good morning. May I know who the presenter is?
Sorry, I could not hear. Sounds
Hello?
Hello.
Yes, sir.
Yeah.
May I know who the presenter is, sir? Who is the presenter?
Diptaman Nandi
Diptaman Nandi and Prosenjit Basu. So they will answer one by one.
Keep question either to Diptaman or to
Diptaman or to Prosenjit.
Right.
Good morning,
So,
madam.
good morning. So the only thing is, I think there are two, either a laptop and a phone,
Yeah.
something is on. So there is an echoing. So if one of them could be switched off, sir.
Sound niche na Soham.
না এটা হ্যাং হয়ে গেছে
স্যার আমরা স্টার্ট করে দিই, আমার তো পিপিটির কোনো দরকার নেই, ওরা ছেলেরা যদি সামনে বসে তাহলেই হবে স্যার, কারণ 8:15 বেজে গেছে স্যার। Dr. Prosenjit, can you please unmute yourself? স্যার দুটো মেশিন চলছে, তাই জন্য ইকোয়িং হচ্ছে, একই কথা দুবার শুনতে পাচ্ছি স্যার। বোধহয় আপনারটা এবং ওই যে পার্টিসিপেন্টরা কি পাশাপাশি বসে দুজনের মেশিন চলছে কি, মানে ল্যাপটপ বা ফোন? Shall we start, sir? So shall we start?
ঠিক আছে
Yes, you can start.
Okay, sir. Thank you, sir. Good morning, students. So, sir has given a scenario where there is a 30-year-old male who has met with a road traffic accident, and he has been brought to the ER in an unconscious state of mind. So, you are the medical officer or the surgery resident in the ER. How will you approach assessing this patient?
Sir, madam, I'm proceed with according to ATLS protocol. First
Okay.
of all, I assess the airway of the patient and stabilize the cervical spine,
Okay.
and then we
So, how
proceed.
will you assess the airway? You said you want to assess the airway. How will you assess the airway?
Ma'am, I ask a few questions to patients, his name, or if he can utter his airway is patent. And
So, sir has given the scenario where your patient is unconscious. So, in
Yes,
that
ma'am.
case, he's not going to respond to your questions, right?
Yes,
So,
ma'am.
so what will be your next step forward then?
I try to open the mouth and check any foreign body or any thing present in the oral cavity or not. If present, I will try to remove it by
More than
giving
foreign
suction.
body, what else do you expect?
Uh, 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 it's
It's a road
maybe
traffic
mucus
accident.
plug or
Mucus plug,
mucus
pardon?
plug or blood
Blood. So
ma'am, mucus
secretions and blood.
plus blood. Yes, ma'am,
Secretions and
secretion.
blood. These are the two main things. And yes, there can be a foreign body. So if it
Yes,
is present, you suck it out. Fair
yes,
enough.
ma'am.
What next?
And don't forget to look for the nares also.
Yes,
The
ma'am.
airway starts from the nares, the nasal cavity, and the oral cavity.
Oral cavity.
So what will you do? So patient is unconscious. You wanted to ask questions. You asked his name and what happened. He did not respond. Now, when you asked the questions, what was your thought? You said that if the patient talks, that means the airway is patent.
Yes,
If
ma'am.
the patient is talking, what other information do you get other than the airway being patent?
Ma'am, I can ask the mode of injury.
No, you have asked the question and patient has responded. So
Yes,
one
ma'am.
one inference is that the airway is patent. What
Yes.
other inference can you make if the patient speaks to you? তুমি প্রশ্ন করলে সে উত্তর দিল এয়ারওয়ে
Yes.
পেটেন্ট আর কিছু কি জানতে পারলাম আমরা তার থেকে
Ma'am, if the patient responded the question I asked, then his conscious level is okay and he's coherent. And the patient is coherent.
So
He may
there are
not be
three
coherent.
things that you must see. See, number one,
Yes.
if the patient talks to you, as you correctly said, airway is patent. That is number one.
Yes.
Number two is that the breathing is also so far good. That means if
Good.
the ventilatory action is not there, then the patient
Yes,
will
ma'am.
not be able to verbalize even if airway is clear. Number
ma'am.
three, he has enough perfusion, cerebral perfusion, so that
Yes,
he
ma'am.
can understand your question and give you a coherent reply.
Coherent reply.
তুমি
Yes,
একটা
ma'am.
প্রশ্ন করলে সেটা অন্য উত্তর দিল, that maybe patient is in shock, he is not understanding what you're saying. So just
Yes,
one
ma'am.
question and answer can give you some information about A, B, and C. Now, our patient is unconscious. You said you want to open the mouth, you want to suck out anything that is present. What else? What next? What's the next step that you will do in your airway assessment?
Uh, I assess the conscious level if it is
He is
uh,
unconscious. He is
if
unconscious.
if its GCS is less than 8.
After he go to the GCS.
You are not thinking of GCS at the moment. He is unconscious. He is not responding to you. You have
Yes.
sucked out his mouth. What's next? What's the first very, very important step next?
Ma'am, I put the airway to
Yeah, you want to put the airway, but
Goodell's
before that,
airway.
will you not want to start him on oxygen?
Yes, ma'am. I assess the breathing and if patient is not breathe well and is not ventilated, then we secure the breathing and if needed, we
Proshenjit,
put them
don't make
on an
Proshenjit,
endotracheal intubation.
Proshenjit,
Yes,
hold on. Don't make
yes,
blanket
ma'am.
statements. It has to be absolutely structured 1, 2, 3, 4. Number one,
Yes,
you have
ma'am.
asked him a question. He has not responded. Number two, you have sucked out his any secretions in the mouth. Number three, start him on oxygen. Okay. Every patient, whatever be conscious, unconscious, every trauma patient has to be started on oxygen.
Started with
How much
yes.
oxygen will you give?
Ma'am,
How much oxygen will you give?
initially on face mask we did 5 to 7 liter.
No, it's a much higher. It's called high flow oxygen. So it has
Yes,
to be 10 to 15 liter to begin with. You can always decrease it later, but 10 to 15 liter of oxygen to begin with. And what mask will you use? Can you give 10 to 15 liters by an ordinary mask?
No, ma'am. NRBM mask we
Correct,
have to
correct.
use.
So you have to use an NRBM mask and give 10 to 15 liter oxygen. And you have to attach the monitors so that you can assess the pulse, PP, respiration, etc.
Pulse PP
Saturation.
respiration. Yes,
Okay.
ma'am.
So now your patient, you have started him on oxygen. You see that the pulse is about 120. Note the findings. BP is around 90 by 60. Okay. Respiration
Yes, ma'am.
is
Yes,
about
ma'am.
25. and a saturation of 85. Okay, these are the situations.
Yes.
So
Yes,
pulse
ma'am.
of 120, BP of 90/60, respiration of 25, and saturation of 85. What is your next step?
Ma'am, we assess the peripheral pulse if it is present.
I told you
We
the pulse is 120.
90. Yes, ma'am. Then we start the IV fluid. First of all,
Have you
we
completed your airway assessment that you're jumping to IV fluid? You have not yet completed your airway assessment. See, sometimes we have a lot of team members, so one person can take care of airway, the another can take care of bleeding, and another breathing, third can take care of circulation. But let us discuss in a vertical manner so that if you are the only person, what will be your priorities? Okay? So you have started him on oxygen. What is your next step? These are your vitals.
Yes, ma'am.
Your friend Diptoman, you can also answer.
Madam, for assessing the airway aspect, we will check whether breathing sounds are present bilaterally in the lungs. Then we will see the saturation SpO2.
Yes,
And
SpO2 is 85%. I told you 85%
85.
SpO2.
And then we will see if there any cyanosis is present.
Please remember, cyanosis is a very late manifestation. So if patient is already cyanosed, that means already patient is in a very compromised situation. So let's structure it this way. See, sir has said patient is unconscious. I'm giving you parameters where the respiratory rate is high and the patient is in obvious shock. If and saturation is 85. Now, in this case, you know, unconscious patient with a low saturation, you have to secure the airway. The GCS at this point, you do not have to know the exact number, but an unconscious patient with a low saturation means you have to secure the airway. So you have already started him on oxygen. In spite of oxygen, saturation is not improving. What will be your next step?
Next step, madam,
Sir,
we
we put the
Speak one at a
if
time, please.
patient does not respond to this high flow oxygen, then
Yes.
we can after suctioning the oral cavity, then we can go for endotracheal intubation and followed
Yes,
by.
you can go for
Then there are
endotracheal
some steps.
intubation. But before that, before
there are
putting
some
an
steps.
endotracheal intubation, endotracheal tube, you must put an oral airway, right? You can
Yes.
put an oral airway that is going to prevent the tongue fall. Unconscious patient might have a tongue fall. So you can put an oral airway. Now, this is a road traffic accident. Do you think you can put an oral airway in all road traffic accidents, or do you have to be selective?
No, madam. In all ultrapulsation, airway tube cannot be given.
Why so? In which patient can you not put?
If
So let's put it this way. Number one, any patient who is conscious, who has an intact gag reflex, you cannot put an oral airway. He's going to start coughing. Okay. Second is, then what do we put? We put a nasal airway in that case. But if you have extensive mid-face injuries, road traffic accident, you might have a lot of mid-face injuries. In that case, you will have to put an oral airway and not a nasal airway because the nose and other bones may be broken. Okay, so we divide into oral as well as nasal airway. So once you put the nasal oral airway and you have started the oxygen mask over the airway, you see that the saturation is improving. Okay, it has come to 90. And you want to secure the airway, you proceed with an endotracheal intubation as you had said. Now that the airway is secure, what is going to be your next step? How will you assess the breathing? Diptoman, how will you assess the breathing?
we will assess the, we have some monitors. We will auscultate the lungs. We will see the expansion of the lungs.
Before auscultation, can you not see your patient is being
Clinically, will
exposed?
you not see
Can
anything?
you not assess that patient is breathing or not?
Yes, we will see the intercostal muscles, or if chest
See, you
is
don't see intercostal
expanding.
muscles. What do you see? Whether there is bilateral equal movement or not of both the sides of the chest. Okay.
Mm.
Now, if it is bilateral movement, that is one thing. Or if you see that one side is moving more than the other side, you have to think that there is some pathology, some problem on the side which is moving less.
In the chest.
So first things first, you inspect, you see whether both sides are moving equally or not. What else do you see? Whether there are any injuries, any contusions, any penetrating wound, anything on the chest which will attract your attention. And only after that, you will palpate. So you look, now you are going to feel. And you will feel for whether there is any rib fracture, because that is going to give you an irregular feel. You will feel whether there is any subcutaneous emphysema. What else are you going to palpate? What else? Breathing does not begin at the chest. Breathing begins at the neck. Okay. So what else will you feel?
Ma'am,
Yes. Yes, Prashanjit.
ma'am, we feel the tracheal position, whether it is
Very good.
deviated in any side or not.
Yes. And what else? One more
And
thing.
uh,
You will also see whether there is an engorged neck vein or not.
engorged neck.
Right. So engorged neck vein,
Yes, ma'am.
any injuries in the neck, that is also to be noted. And as you
Yes, ma'am.
correctly said, whether the trachea is deviated or not.
Yes, ma'am.
After this only, you're going to auscultate. Okay.
Yes, ma'am.
Auscultate to hear whether there is equal breath sound or diminished breath sound at any
Ma'am,
side.
whether we do percussion or not,
No,
Right.
visual examination is not required at this stage. This is the
See,
initial
percussion
assessment.
is an obvious theoretical answer. Yes, in your exam, you may say percussion. But percussion is very tricky in a trauma situation, because if there are rib fractures and
Yes,
another
ma'am.
things, if you percuss, it is extremely painful for the patient. Secondly, appreciating a dull or a resonant sound is very difficult in an ED. It is usually a noisy, chaotic place. So appreciating whether your percussion sound is dull or not is very difficult. So it is better to inspect, palpate, auscultate, and then percuss. If you see it is diminished on one side, then you can consider doing a percussion to see whether that side is dull. If it is diminished and dull, it is blood. If it is diminished and hyporesonant, it is a pneumo.
It is
So that way you can
pneumothorax.
see.
Yes,
But percussion itself in a practical ED is very, very challenging.
yes,
So
ma'am.
you have evaluated the chest and you see that air entry is equal. There is no evidence of any engorged neck vein or tracheal deviation. No external injuries on the chest, and air entry, as I said, is equal. Any other information you want from me other than what I have given you? You will also want to know whether you can hear the cardiac sound.
Yes, yes, ma'am.
Right? So that you must know. I know I had told you that the neck veins are not engorged, but you must always want to know that, madam, can I hear
Yeah.
the cardiac sounds? If the cardiac sounds are audible, you're happy. If not, if they are muffled, then it may mean that there is a cardiac tamponade.
Cardiac tamponade. Yes,
Right?
ma'am.
But a cardiac
Yes, ma'am.
tamponade will always be associated with a raised neck vein.
Mm,
So
yes,
there are
ma'am.
two
Engorged neck
situations
vein.
where you will get a raised neck vein. One is a cardiac tamponade. The other is, what is the other situation where you get a raised neck vein? What is the other situation where you get a raised neck vein? Diptoman? One, he said,
Anything in the lung
cardiac
catheter?
tamponade. What is the other situation in which you get a raised neck vein?
Lung consultation cannot come in emergency.
Tension
Tension
pneumothorax.
pneumothorax.
Tension pneumothorax.
See, that's an obvious answer because these are life-threatening injuries. You cannot do anything with these patients, cannot send them anywhere for any investigation till you have sorted it out. So two very important things: raised neck vein, patient with diminished movement or decreased sound on this side, it means it is a tension pneumothorax. Raised neck vein, audible breath sounds, but diminished heart sounds, cardiac tamponade. Another point that you have to remember is if the patient is in shock, like your patient, then even if there is a cardiac tamponade, or a tension pneumothorax, you may not get a raised neck vein. So if a patient is in severe shock, you may not get a raised neck vein. So don't get carried away that there is no neck vein, meaning patient is all good. Okay, you will still have to evaluate by the heart sounds and the cardiac sounds. Okay, okay. Now you come to circulation. What are you going to do,
Yes, ma'am.
Roshanji?
So, ma'am, I will palpate the peripheral pulses. If it is,
Monitor is already there showing you a pulse of 120.
yes, ma'am. So then I go.
You are not audible. Yeah, come in. Yeah, please, yeah, now come in.
I will
Do
go
you really get a 14 French cannula in our emergency setup?
in
I
emergency.
hardly find a 14 French cannula. It is there in the book.
Yes,
It's true.
but
Ah,
What
we
is
go for
the minimum that you, what
large
is the
bore
maximum
cannula,
that you
wide
can,
bore cannula.
wide bore cannula? Yeah. So just say wide bore cannula. But yes, please don't go into a pink cannula. It should be green and above. What color is 14, by the way? I think
Green
you
and
said
above.
14. What color is 14?
Orange.
Orange. Have you seen one? I'm sure no. Yeah. So let's be realistic. So
No.
it is either going to be an 18 green or a 16 gray if you get one. But the idea should be there should be a white bore cannula. Okay. What fluid will you start?
Wide bore cannula.
What fluid will you start?
I start with a normal saline, crystalloid.
Crystalloid. So you want to start with an what sort of crystalloid? 5D?
Normal saline, ma'am.
Normal saline. So what is it? You will say, I'm going to start with an isotonic crystalloid.
Isotonic crystalloid. Yes, ma'am.
Isotonic crystalloid. Warm crystalloid. Thanda noy. We don't want isothermia, hypothermia in the patient.
Hypothermia.
So
Yes,
warm
ma'am.
crystalloid, isotonic crystalloid. How much?
Isotonic.
How much will you start? How much fluid will you start?
1 liter initially. Then
1 liter initially. That means you need 2 IV lines in 2 hands, right? Okay.
Yes,
Why
ma'am.
1 liter? Why not more? Why 1 liter?
Ma'am, I look for response of the
No, the point is you said you're going to start with 1 liter and only then you are going to see response. So why do you want to start with 1 liter? Why not 2 liters? বেশি দিলে বেশি বিপি উঠবে ভালোই তো
it may lead to volume overload if I give more fluid.
You do not want to do
want
volume.
to
Why
bring
volume
the BP
overload?
to
Why
very
you
high
worried
side.
about?
And I also want the BP to raise a certain level. After that, if it raises, it may leads to more bleeding, internal bleeding, or anything else
So the
I
point is
still
that you
not
are going to give fluid, number 1, to replace the volume loss, number 2, to improve the blood pressure, and number 3, to improve tissue perfusion and oxygenation. These are my 3 points as to why I want to give fluid, right? But if I give more fluid, as you correctly said, then there might be further rise in blood pressure leading to further bleeding.
bleeding. Yes, ma'am.
Right? So in different cases, in a penetrating injury, suppose this patient has a penetrating injury, what will be your target blood pressure? What will be your target blood pressure?
When you are happy, yes, I will not give more fluid, I'll just maintain now. What systolic will be optimal?
Ma'am, above 90 is
See, in a penetrating
systolic.
injury, you stay even lower. In
Yes.
a penetrating injury, you want to maintain a BP of around 60 to 70 till you have achieved hemostasis, meaning if there is a big bleeding wound or if there is, suppose there is a fracture, a compound fracture femur, which is bleeding, or there is an open laceration wound. So you want to keep it, or even an intra-abdominal injury where you know you have to take the patient to OT. So you like to maintain it at 60 to 70 because number one, if you raise the BP further, there is going to be more bleeding. Number two, you might cause coagulation, dilutional coagulopathy. You give so much
Dilution,
fluid that the patient has dilutional coagulopathy.
dilution,
But if it is a blunt injury, then what is the target BP?
ma'am, systolic blood pressure above 9.
Yes, so it is 80 to 90 in blunt and 60 to 70 in penetrating. Now,
Penetrating.
our patient has head injury, right? Suspected head
Yes.
injury because he's unconscious. What will be your target blood pressure for him?
Ma'am, I needed good higher systolic blood pressure to maintain the cerebral perfusion.
Correct. So we target at around 100 to 110 systolic
100.
if in a patient with a head injury. Now,
Head
why
injury.
do I want to target that 100 to 110? What happens if the BP is lower in these patients? A patient with head injury, if the BP is lower, what happens to the patient?
Ma'am,
Yes,
ma'am, cerebral perfusion is compromised and
leading to
leading to perihemorrhagic ischemia of
so
the
that
brain,
so we don't have to
cerebral
be anatomically correct here. What we are going to say is a primary brain injury has already occurred because of the accident. We want to avoid secondary brain injury.
brain injury.
And secondary brain injury is caused by hypoxia and hypotension. So we would like to give number one oxygen and secure the airway, which you have already done. And we would like to maintain the BP at 100 to 110 systolic so that secondary brain injury due to hypoxia and hypotension can be avoided. Clear? Okay. Now you had said, again, I'm going back to a previous question where you said you want to start 1 liter. I agree with you, but why the 1 liter? Even 2-3 years back, it was much more. So why is it 1 liter? How did you come to that calculation?
And even in elderly and cardiac compromised patient, it should be 500 ml. It should not be 1 liter at the first go.
See, the idea is if you know the grades of shock, do you know the grades of shock? Grade 1, grade 2,
Yes,
grade 3, grade 4?
Yes, ma'am.
Right.
Yes, ma'am.
So in grade 1, 15% of the blood volume is lost.
Yes,
Grade
ma'am.
30%,
15 to
grade
30.
3,
Yes.
45, and grade
Yes.
4 is above.
More than
In grade 1, there is no change in the hemodynamics of the patient, right? Pulse BP does not change.
yes,
In
ma'am.
grade 2, there is tachycardia. In grade 3, there is a decrease in pulse pressure. That is,
Pulse
the
pressure.
systolic remains same, diastolic rises.
Yes, ma'am.
So for a patient to manifest shock, that means he has at least lost, he's already in grade 2 or 3 hemorrhage. That means he has already lost 30 to 40% of his blood volume,
Blood
which
volume.
is equal to 1 liter.
1 liter. Yes, ma'am.
So if a patient is manifesting shock, that means already 1 liter has been lost. So my target will be to replace that 1 liter to begin with. But if you
Yes.
note what sir said, if it is an elderly patient, if it is a cardiac patient, you have to stay on the lower side so that you do not cause a cardiac overload. But the practical thing is that when a patient comes, we hardly ever know whether he is a cardiac patient or not. Yes, elderly patient, we can keep the physiology in mind. So you have given 1 liter. What do you do next? How do you assess and decide whether I'm going to give more fluid, or I'm going to stop here, or I'm going to give something else? How do we assess?
Ma'am, I assess the vitals and whether it is responding or not, or it is transiently responding, or it is non-responding.
Correct.
It-
So
it
depending on the
is-
response, you decide whether to give more fluid or not, right?
Yes.
Okay.
Yes,
So
ma'am.
let's say that the patient is a transient responder. Okay. The
Yes, ma'am.
gray zones are always the tricky zones. He's a transient responder. What will you do next?
What is the implication of transient responder? Implication.
Ma'am, I go to find any active bleeding source if present or not. If present, I have to secure it first. Then I continue the resuscitation.
Okay. So you said you want to secure the bleeding. So what could be the potential sources of bleeding?
Uh, yeah, external. It might be external injury.
Okay.
An internal. It may be the thoracic cavity, abdominal cavity, pelvic cavity, or it's maybe long bone fracture.
Very good. So external bleeding, how will you control?
By putting pressure bandage.
Absolutely.
Initially,
So you
compression.
can
Yeah.
pressure it. If there is a cavity, you can pack it.
Yes,
Or
ma'am.
if it is a torrential bleed, you can think of putting a tourniquet, applying a tourniquet and noting the time, right?
Yes.
So
Yes,
that
ma'am.
is one is bleeding control. So if it is again, I come back, if it is a transient responder and there is no evidence of external bleeding, you know that you have to shift the patient to OT because you have clinically and with your EFAST detected a hemoperitoneum. Then what fluid will you give now? Your 1 liter is over. What fluid will you give now?
Uh, we go for blood transfusion, ma'am.
Want to go for blood transfusion.
Yes.
Now, the usual thing in all our hospitals is they say that blood will come after 1 hour, isn't it? So what do you
Yes,
do
ma'am.
till then? You're not going to wait, are you?
We can give hemaxil or this type of colloids.
So you think of want to give colloids. Okay, Diptoman, what are the advantages of giving a colloid?
Giving colloids, number one, it will replace some part of the lost volume.
So it
And
is a volume expander. That is what you're saying. Okay, but what are the problems?
problems that it can cause overload.
Okay,
Shock
no,
vision
not
was
really, it doesn't. So what are the problems? What other very serious
is
side
that?
effects can be there with initial colloid resuscitation?
What can happen in the pulmonary bed?
So you have to remember that yes, it is a very good volume expander, but it can cause acute renal injury in a shock
Oh,
patient.
Yeah,
This is
AKI,
the AKI.
AKI may take.
Okay.
So this patient will ultimately land up with a hemodialysis. Okay, so you have to check that. Secondly, not only initially the AKI is the commonest, but synthetic colloids, you have these Hestarch and all that. They can cause multiple organ failures also. Okay. And in a patient with head injury, if you give something like albumin, it has been shown to cause higher mortality. So colloids do not offer any advantage in the early resuscitation of the patient. You may give it later once you control your hemorrhage and everything, but in the early resuscitation, no role of a colloid. Okay. So crystalloid
And also
1
they
liter
cause
over.
impairment of cross matching. They cause also impairment of cross matching of blood. Some colloid.
Okay. So now colloid I will not let you do. Crystalloid 1 liter over. What next? If blood is not available, then what do you do?
Madam, we can give renal lactate or
He has already started crystalloid, isotonic crystalloid, and 1 liter is over. So the point is, if try to give blood as early as possible. If blood is not available, you may give 200 to 250 to 500 more of crystalloids in small boluses. Do not just run a bottle and go off. Wait there as early as possible, start blood. Now, if your blood bank says that no, আমাদের cross match করতে আরো সময় লাগবে, in that case, you can consider starting O negative uncross matched blood. This is a life-threatening situation. এই 1 ঘন্টা পরে blood আসবে জন্য বসে থাকতে আমরা পারবো না. So you can consider starting. So first and foremost, 1 liter crystalloid. Hopefully by that time the blood will come. If it is not coming, 250-500 করে একটু করে small boluses দেওয়া, not a blanket blood transfusion. Again, reassessing the patient's response. Everything is going to depend on patient's response. If the patient is a non-responder, you have to rush the patient to OT to achieve surgical control of hemorrhage. But you must ask for O negative cross-match blood from the blood bank till they can cross-match and give you the correct blood. Okay?
Yes,
What
ma'am.
else can you do? ব্লিডিং বন্ধ করার জন্য আর কি করতে পারো?
Madam, we can give this tranexamic
Very good.
acid.
So you can give tranexamic. When can you give tranexamic? How much can you give tranexamic?
Madam, 1 gram stat IV.
পেশেন্ট কালকে রাত্রিরে অ্যাক্সিডেন্ট হয়েছে, তোমাকে বাঙুরে ইডিতে নিয়ে এসছে আজ সকালবেলা 7-8 ঘন্টা পরে। Will the tranexamic acid help him or not?
No, ma'am.
No. So বলো প্রসেনজিৎ, বলো তাহলে কি করব?
Ma'am,
দেবো দেবো না, কাকে দেবো?
tranexamic acid, ma'am, it is platelet dependent. So, the initial,
See,
active
the answer is very
bleeding
clear.
হয় আর
Let's not be ambiguous about it. There is a trial called the CRASH 2 trial. CRASH 2, second trial. CRASH 1 ছিল, but CRASH 2. They have said very clearly that if the patient presents within 3 hours of the injury, then give 1 gram IV over 10 minutes. Not a just pushing. 1 gram IV over 10 minutes. And after that, give 1 gram over the next 8 hours. That is the dose. Not BDTDS like we do in an elective situation. Okay. So CRASH 2 trial says 1 gram IV over 10 minutes if the patient has arrived within 3 hours. And following that, you can give 1 gram over 8 hours. So if you say that the patient has arrived 7 hours, 8 hours later, you may give, but there is no added benefit and there is no improvement in mortality or any or outcome of the patient by giving tranexamic acid. Okay, so you have started fluid, you have asked for blood, you have given tranexamic acid. There is no evidence of external bleeding. BP now he is gradually responding. What will you do next?
we assess
Is
the
there any investigation you want to do at this moment?
ma'am, in primary survey we can do only 2 investigation. It's chest
Okay.
X-ray and E-fast.
Okay. So what information are you asking for in an E-fast?
In
What
E-fast,
information are you asking for in E-fast?
we look any any pericardial collection or any pleural collection is present or not. Then we go for any liver injury and splenic injury.
No, don't assess the liver.
Do we look for liver and splenic injury? E-fast cannot tell you which organ
No,
is
ma'am.
injured.
Any collection is present on
Exactly.
in
So any collection, and where do we look for the collections?
in pelvic cavity, in the right hypochondric region, left, and in pleural cavity.
Okay,
And
so that makes it a little more clear. There were some errors and some correct answers. See, fast means you look for fluid within the abdominal cavity.
Yes,
The fluid can be blood, could be intestinal content, could be bile, anything. That fast will not be able to tell you. But in a trauma situation, assume it is blood till proven otherwise. Okay. Number 2, where all do we see? Do not say hypochondrium, just say the area between the diaphragm, liver, and kidney on the left side, and the area between the diaphragm, spleen, and kidney on the left side. So on the right side, the area between the diaphragm, spleen, and kidney and liver, and on the left side, diaphragm, spleen, and kidney. These are the 2 areas that you see in the upper abdomen. In the pelvis, we look at fluid around the bladder. And in the epigastric region, we actually assess the pericardial space. These are the 4 spaces. In the lungs, we look for fluid within the peritoneal cavity. So fast is the 4 quadrants of the abdomen, and E-fast is when you also evaluate the chest, the thoracic cavity. So you are allowed to do an E-fast. Now, patient is E-fast positive. patient is EFAST positive. What other information would you want? Patient is EFAST. Are you there?
Means patient has some collection.
Some collection.
Yes.
Yes. What other information would you want?
Any abdominal organ injury.
Okay, so that's all the information EFAST will tell you. EFAST cannot tell you whether it is the spleen or the liver. Yeah. So what other information is relevant to you at the moment?
Madam, CS status.
No.
কি বুঝতে পারলাম না, আরেকবার বলো।
There is a lead intent. So what? Next.
তোমাদের ছবিটা একটু অন থাকলে আমার সুবিধে হয়, otherwise I don't know who I'm speaking to. All the images have gone off. So if EFAST is positive, yeah, sorry, bolo, হ্যাঁ বলো। Deeptaman, bolo.
Try to assess the whole of this bleeding or the source of this collection.
See, intra-abdominal, that's all I told you. Patient has intra-abdominal bleeding. Source আর কিছু জানি না, বাইরে কিছু নেই। Thorax clear. Epigastrium মানে pericardial cavity clear. So it is an intra-abdominal bleeding. তুমি আর কি জানতে চাইবে আমার কাছ থেকে? So all you want to know is the hemodynamic status of your patient. Now let me give you two patients, patient A and patient B. Both have fast positive, but patient A has a stable hemodynamic condition and patient B has an unstable hemodynamic condition. Now তুমি এই দুটো পেশেন্টকে নিয়ে কি করবে? Yes, Prashanjit, patient A, fast positive, hemodynamically stable. কি করবে? Your sound is off, Prashanjit. You need to switch on your audio. Yeah. বলো।
We'll proceed for further investigation to
What
like
further investigation?
CECT,
See,
whole abdomen to identify and delineate the exact source of injury or any visceral injury or present or not.
আচ্ছা দেখো, তাহলে পেশেন্ট যদি হিমোডাইনামিকলি স্টেবল হয়, the basic principle is you don't rush to OT with the patient, right?
Yes.
You want to further evaluate. Now your CT scan tells you that there is a laceration in the liver. What will you do next?
Ma'am, up to grade 3 we
Hemodynamic stability.
Patient is
ma'am,
hemodynamically
if
stable.
he is ma'am, we grade the injury if it is more than
to grade the injury? See, get your concepts very clear. It's not important to know whether it's a grade 2 or a grade 3. The point is whether that injury is causing a hemodynamic disturbance or not, right?
yes.
So if the patient
ma'am.
is hemodynamically stable, then we do not go in for any operative intervention, even if an injury is picked up on CT, except what, Diptoman? কোন situation এ patient stable আছে, তাও I might want to go in for an surgical intervention. আর কি দেখবে?
Madam,
Might be partial liver injury. Can there be anything else which might dictate a laparotomy?
See, two
any,
things. Number one,
this
patient who is sorry, bolo.
associated organic injury like splenic injury or
Now patient stable hemodynamically. খুলবে patient কে
When
উচিত?
splenic injury.
So let's get it clear. Number one, আমি বলে দিই, শোনো। Number one, patient hemodynamically stable, patient does not go to OT. Okay, you give what is called a non-operative management. কিন্তু তার মধ্যেও if the patient has a penetrating injury, he will be needed to be taken to the theater. If the patient has features of peritonitis or guarding where you suspect a hollow viscous injury, then you will have to, even blunt trauma can have hollow viscous injury, right? In that case, even if patient is hemodynamically stable, you will take the patient to OT. Sometimes we do not wait for the CT because if there is frank features of peritonitis on the basis of clinical suspicion also you may take. But it is good to say that if the patient is hemodynamically stable, I can spare half an hour more for the CT and then take the patient to the theater. There is one more injury which is very easily missed, and that is mesenteric injuries. So the blunt traumas are very easily taken care of by the solid organ injuries are usually taken care of by nature. They control the bleeding. But if there is a hollow viscous injury, a mesenteric injury, or any penetrating injury, then you will have to take the patient to the OT theater. If the patient is unstable, no questions asked, no investigations required, you can shift the patient directly to the theater. So let the dictum be very simple. Stable patient goes to CT, unstable patient goes to OT. Okay, that way there should be no confusion. শুধু stable একটা আরেকটা algorithm আরেকটা limb থাকবে which will say that even if the patient is stable, if there are penetrating injuries or evidence of peritonitis or any mesenteric injury, then we will take the patient to theater. Clear about it? তাহলে ততক্ষণে blood এসে sorry কিছু বললে? Okay, so you've taken care of C. What next? Patient এর ধরো intra-abdominal সেরকম কোনো injury নেই. What next?
Assessment of neurological disability.
Okay, neuro. So very important thing, disability means neurological disability, not orthopedic disability. Okay. Okay. Assessment of neurological disability. How will you assess neurological disability?
We proceed with AVPU if patient is alert, or it respond with verbal command, or it respond with pressure stimulus, and if he is unconscious.
Yes, so you can do AVPU. Yes, you're right. Or you can, if you can assess the GCS also. They are both markers of this, right? So you have assessed the GCS, and our patient was unconscious, if you remember, right? So
Yes,
sir has said that the GCS is, let's say, 6. Okay.
Yes.
So what will you do next? What will you do
This 6 means what? An injury or major severe injury?
Severe injury. It's
And what should be done immediately?
Endotracheal intubation and putting the patient in invasive ventilations.
Okay, so
If
that was
it's-
already done. তুমি airway যখন করেছো তখনই তুমি করে দিয়েছো. You remember we said that we are not so keen on knowing the GCS, but securing the airway was more important in an unconscious patient. So you have taken care of the airway. Now what else do you want to do? Your patient is GCS 6, patient has been intubated, patient is hemodynamically has been stabilized by you. What will you do next? তোমায় তো জানতে হবে কেন unconscious.
we go for NCCT brain to
NCCT brain. Okay, NCCT brain. আচ্ছা, তুমি এই NCCT brain করার আগে any medications that you would like to give to the patient?
IV fluid.
IV fluid তো দিচ্ছ, medications. কিছু মেডিকেশন হেড ইনজুরি পেশেন্টকে আলাদা করে দেবে তুমি, যেটা নন হেড ইনজুরি পেশেন্টকে দেবে না. লেটস সে দ্যাট. ইয়েস দীপ্তমান বলো.
Mannitol
No, you cannot give blindly.
আচ্ছা, ম্যানিটল তুমি কাকে দেবে কাকে দেবে না? স্যার পাশ থেকে বললেন ব্লাইন্ডলি দেব না. কাকে দেবে কাকে দেবে না?
Ma'am, if
বলো,
there
বলো.
is any suspicion of raised intracranial pressure, then we give the mannitol. Otherwise,
Raised intracranial pressure.
Compressing hematoma will cause ICP increase. Compressing hematoma.
yes, ma'am. Yes, sir.
Will you give mannitol for all patients?
No.
সবাই এত কিছু যখন বলছে নিশ্চয়ই সকলকে দেব না তার মানে, তাই না? নইলে তো সহজ হয়ে যেত উত্তরটা। So let's get things clear again.
Yes, ma'am.
Till you do your CT scan, you do not give mannitol. Number one. Why so? If a patient has an extradural hematoma, a mannitol should not be given. Extradural মানে কি dura আর bones এর মাঝখানে। So তুমি যখন mannitol দিচ্ছ, it is like a diuretic of the brain. It is going to shrink the brain, right? If it shrinks the brain, that space, extradural space is going to increase. So there is going to be further collection of blood, further pressure symptoms, further brain injury. So if there is an EDH, I will not give mannitol. If there is an SDH, yes, I can give mannitol. Again, everything as an exception. If you have an EDH and you see that the patient is deteriorating very fast, maybe there are symptoms of brain herniation. In that case, তোমার হাসপাতালে যদি neurosurgical facility থাকে, তুমি one shot of mannitol দিয়ে you can shift the patient to OT. But if you do not have the facility, do not give mannitol, and definitely do not give before doing a CT scan. Okay?
Yes. Yes.
Anti seizure drugs, anti-epileptic drugs দেবে head injury patient কে?
If active convulsion is present, then we prescribe.
So there is no role of prophylactic anticonvulsants. যে আমি eptoin দিয়ে দিলাম loading dose, no. যদি patient convulse করছে তাহলেই তুমি দেবে, না হলে দেবে না। ঠিক আছে? So fluid has to be given such that the BP is around 100 to 110 systolic. No role of mannitol till you have ruled out an EDH. No role of anticonvulsants unless the patient is frankly convulsing. Okay? আর কি করবে?
Expose the patient under controlled environment to look for any other source of.
I'm still in D. তুমি GCS দেখেছো, আরেকটা জিনিস কি দেখবে?
What is GCSP?
Pupillary reaction.
Exactly.
To light.
Must see the pupillary reaction, not only reaction. আর কি দেখবো? একটা তো patient pupils react করছে কিনা, আর কি দেখবো? Whether they are equal or not.
Equally reacted or not, yes.
Equally reacting na. Size.
You know the pupillary.
Yes, sir?
PRS, pupillary reaction score. Pupillary reaction score. Pupillary reaction score.
বলো।
How do you score pupillary reaction? Both people reacting to light. Score is
0.
0. Yes.
If one reacting, then it's -1. It is both.
Not -1. It is 1.
It is 1. If both react non-reacting, then it is 2.
And how is the GCSP scale arrived at?
GCS, the total from total, it is GCS minus P.
So basically the pupillary reaction decreases, I mean, it signifies a more critical condition. If there is a P factor, that means the score goes down.
Yes,
so it is a more critical condition. Okay, let's say that the patient has had a spinal injury. Okay, a spinal injury. He is talking to you, he's conscious but unable to move any of his limbs. Probably a cervical spine injury. Okay, how will you assess the GCS? How will you assess the GCS? দেখো ভার্বালটা এ করা কোনো অসুবিধে নয়,
মোটর
আই ওপেনিং এ করা কোনো অসুবিধে নয়, মোটরটা আমি কি করে অ্যাসেস করব তাহলে?
ওবে কমান্ড মানে জিপটা বার করুন বা এই ধরনের।
এক্স্যাক্টলি। সো প্রথম কথা যেটা তোমায় মনে রাখতে হবে, GCS is not a modality to assess neurological function of the limbs. GCS is only a score to assess the function of the brain. Okay, so spinal injury te GCS দিয়ে কিছু judgment করব না। Second হলো যে if the patient is paraplegic or quadriplegic, as I said, then yes, the cranial nerves are still functioning. তুমি মোটর তাইকে করতে পারো. Ask him to puff his cheek, ask him to raise his eyebrows, ask him to, take his tongue out. So these will also, if he can do it, that is an M6, even if he cannot move any of his limbs. If there is a spinal injury, are কোনো specific drug needs to be given right away?
Steroids, madam?
Steroids. কেন steroids দিচ্ছি?
Any neural inflammation?
So there is a spinal injury. There may be associated vertebral injury with spinal injury. There is bound to be a cord edema. You want to minimize the cord edema. So that if cord edema is there, there is going to be further damage to the spinal cord. Okay? আর কি করবে spinal injury তে? If the patient has come, তোমার যে পেশেন্টটা স্যার বললেন, সে এসেছিল 30-year-old man, RTA, আমি একটু সিনারিওটা চেঞ্জ করছি, he is still unconscious. আমি ইনিশিয়ালি তোমাকে বলেছিলাম না, pulse was 120, BP was 90/60. এই ক্ষেত্রে আমি সেকেন্ড সিনারিও দিচ্ছি, same 30-year-old man, RTA, ERA, he is unconscious. You've seen the pulse and BP. Pulse is about 100, BP is about, let's say, 80/60. কি ভাববে তুমি?
Madam, we will put a central venous catheter and
In a shock patient, can you put a central venous catheter?
Primary management is not putting a CVP.
Central venous has no role in primary management. Okay. See, you have to suspect. See, he has a hypotension. He has a hypotension with, sorry, I had given a little bit wrong information, with a bradycardia. Sorry, I said 100 pulse rate. I'm sorry, my mistake. So let's say that the pulse is around 50 and the BP is by about 80/60. So hypotension with a bradycardia. What will you think?
cardiac tamponade chance.
It is a
Sir, শুনতে পেলাম না স্যার কি বললেন?
You said bradycardia, cardiac tamponade.
No, cardiac tamponade.
raised intrathoracic pressure.
বলো। So if you have hypotension with no tachycardia, আমরা নরমালি কি হাইপোটেনশনের সঙ্গে ট্যাকিকার্ডিয়া এক্সপেক্ট করি, কিন্তু হাইপোটেনশন আছে কিন্তু নো ট্যাকিকার্ডিয়া, তাহলে কি টাইপ অফ শক অ্যান্টিসিপেট করছি আমরা?
নিউরোজেনিক।
এক্স্যাক্টলি। সো কনসিয়াস পেশেন্ট হলে তুমি তাকে হাত পা নাড়িয়ে দেখতে পারো, কিন্তু আনকনসিয়াস পেশেন্ট হলে, if you have hypotension with no tachycardia or bradycardia for that matter, then you will suspect a neurogenic shock. How will the limbs feel? How will the limbs feel? তুমি যখন পেশেন্টের গায়ে হাত দিয়ে দেখছো, হাতে হাত দিয়ে দেখছো, how will they feel?
Warm.
They will be warm. So তুমি একটা 90/60 তে নরমালি তুমি এক্সপেক্ট করবে যে ওর একটা কোল্ড ক্ল্যামি এক্সট্রিমিটি হবে, বাট ইন নিউরোজেনিক শক, even though the BP is low, you will not get a cold clammy extremity. You will get what is called a warm extremity. So you will have hypotension and bradycardia. So তোমার fluid challenge কিরকম হবে? Is it going to be any different from a patient who is in hemorrhagic shock? So you have to remember that in a trauma patient, even if there is neurogenic shock, there is always an associated component of hemorrhagic shock. Okay? The neurogenic shock থাকলেও সঙ্গে কিছুটা hemorrhagic shock আছে। তাই আমার যে ইনিশিয়াল প্ল্যানিংটা ছিল of starting with 1 liter of isotonic crystalloid, that stays. You still stay with that. তোমার hemorrhagic componentটা once it is corrected, তখনই তুমি বুঝতে পারবে যে এবারে আমার নিউরোজেনিক শকের কম্পোনেন্টটা চেঞ্জ করতে হবে, and there is where the role of steroids come in. So তুমি নিউরোজেনিক শক মানে আমি ফ্লুইড দেব না তা কিন্তু নয়, you will still give the initial resuscitation, but you will see that the BP will rise a little bit, but the tachy is not happening still. So that will tell you that yes, this patient is in a neurogenic shock. Okay. So you have assessed the ABCD. What next?
E, ma'am. ABCDE. We expose the patient in the control environment to look for any other injury or any external any extra wound present or any active bleeding is present in other sites also.
Okay. So to be controlled environment bolte ki buঝছো?
The ambient temperature should be normal room temperature to prevent
So we want a normal
hypothermia.
room temperature. We do not want any element of hypothermia.
Hypothermia,
right?
yes.
So you
Yes,
have to take care that the AC is off if you have an AC in your AT. The patient should be well covered. খুলে সব দেখছি আমরা, তারপরে patient যেন immediately covered হয়। যদি hypothermia হয়, what can happen? Patient যদি আরেকটা যেটা বললাম warm fluid. So three things: environmental temperature control, cover the patient, give warm fluid. যদি hypothermia হয়, what can happen? What are the complications of hypothermia in a trauma patient? What is the lethal triad?
Hypertension, coagulopathy.
How will happen?
Yes.
There will be vasoconstriction. This will lead to what?
Hypertension, coagulopathy, আরেকটা কি হয়?
Decrease perfusion.
So কি হয় তাতে? Decreased perfusion হলে what happens to the metabolism? Is it an anabolic or a catabolic? Sorry? Acidosis. So the lethal
Hello?
triad is hypotension, acidosis, and coagulopathy. Right? So if you have a patient who is already
Yes.
in shock and there is hypothermia, then there is always a chance of developing coagulopathy and acidosis, and you might lose the patient. So you have to take care of the temperature control of the patient. তুমি বললে are examining any other part, there may be missed injuries, so you might have, this is a time when you might have to turn the patient or log roll the patient to see whether there are any injuries at the back. Okay? So you've completed your ABCDE. What else will you do now? What are the adjuncts to the primary survey? What are the adjuncts? কি কি করতে পারো? Investigation তুমি during primary survey কি কি করতে পারো? বা কি কি adjuncts use করতে পারো?
Ma'am, in primary survey, only chest X-ray and E first.
Another X-ray which may be required, সবার না লাগলেও pelvic X-ray.
Pelvic X-ray, yes, ma'am.
So chest, দুটো X-ray, chest X-ray and pelvic X-ray and E fast. These are the only.
Dr. Chalaji, we will conclude today. We'll conclude today, 9:15.
Okay.
We started late.
Okay, sir. Okay. Thank you. Thank you both.
Individual injuries afterwards.
Okay, sir. Sure. Thank
So
you,
you
sir.
should study the basic things. When you are given the primary scenario, it should be methodically. Okay.
Oh,
Thank you. Thank you, ma'am.
Thank you.
thank you. Thank you.